So basically, our project is to evaluate the impact of Sure Start Northern Ireland using linked administrative data and a naturally occurring experiment. That I'll sort of explain later. But I'll sort of give you, Sure Start is a very well-known policy, but I'll give you a brief overview of it. Sure Start in Northern Ireland is an area-based initiative that offers a range of services to families with children under 4 from pregnancy onwards, and it is aimed at all families within some of the most deprived areas of Northern Ireland. Um, and unlike Sure Start as a program itself was first introduced in England in 1999, but Northern Ireland developed its own program in the year 2001. And it basically, what is offered in each Sure Start centre can sort of differ from centre to centre as they're supposed to respond to the needs of the local community. But typically, it's a mix of home and centre-based services. So there'll be quite a lot of parental support. But with relation to maternal and infant health, there's quite a lot of antenatal and postnatal support, advice from health visitors who might be based within a centre or offer drop-in sessions, breastfeeding support, and there's certainly quite a lot of child play and education sessions within it. And as I mentioned before, everyone who is living in a Sure Start area can receive services. So one of the aims of Sure Start is to be non-stigmatizing by targeting areas rather than entire individuals. Um, and basically, we set out to evaluate, well, that's all very well and good, but does living in a Sure Start area have an impact on mothers and children who are eligible to receive those services? And the way that we've done it is to spot a natural experiment within the Sure Start program. So it was introduced in the year 2001, but it's had two major expansions in the last sort of 20 or so years. So in the year 2006, it was decided to expand Sure Start to at least the top 20% most deprived wards in Northern Ireland. So that took, by our estimation, Sure Start from 108 wards to 190 wards. And in the year 2013, the expansion, there was another expansion to increase it to the top 25% of most deprived areas, but they used a different area in that sort of expansion. But the thing to notice is those numbers 20% and 25%, because that policy target, as you can see in the graph on the right, shows that being the top 20%, being the top two deciles of deprivation greatly increases the chances of an area receiving Sure Start. It's not guaranteed because there's some logistical issues, but as you can see, the chances grow enormously when you're in the top 20%. Um, and that basically leads us to our natural experiment. So we know the numbers 20 to 25% are important for Sure Start, but are they intrinsically special? For example, does low birth weights in areas suddenly spike up enormously at around the 20 to 25% mark? Is the number 20% more important than the number 21%? And the answer is, we've done background digging, but the answer is no. So the numbers 25 to 25% are special simply because they're an artifact of something called round number bias in human beings, which is that people like neater numbers, neat round numbers that end in zeros or fives. So we like to celebrate milestones in terms of 10th anniversaries, 15th anniversaries, or we like to target policies towards 20%, 10%, or we don't target them towards 12 and 13. And we're going to exploit that in evaluating Sure Start. So to do our evaluation, we need to have data on children and mothers. And to do that, we accessed routine administrative data collected by Health and Social Care in Northern Ireland from their data warehouse, and we accessed it through the Honest Broker service, which gives us access to this type of linked administrative data where individuals, including every child born in Northern Ireland, is linked to several data sets using something called their health and care number, which is basically their NHS patient number in Northern Ireland. And it's a unique identifier that's given to children from birth, which is very handy for us. And from that, we started with the Northern Ireland maternity system, which is this really big collection of data from NHS Northern Ireland around every child born in Northern Ireland. And we looked at every child born between the year 2006 and 2020, which gives us a really big birth cohort of 230,000 children living in hundreds of areas. And we basically took data from booking appointments, from birth, from postnatal and health visitor visits, and linked it with other administrative data sets, such as children's social care data from SOS care, hospital data on A&E and inpatients, and also dental data collected in Northern Ireland. And we basically use that to look at outcomes for children and their mothers. And the way that our sort of research design works for evaluating impact is the design itself is something called a regression discontinuity design. And I'm going to have to spend a bit of time deciphering what these graphs mean. So let's say there's a hypothetical case of maternal BMI. If we looked at average maternal BMI in all the areas and then plotted the areas by their deprivation score on the x-axis, and the y-axis is the average maternal BMI, we would probably notice a trend that looks like the one before you, which is that, as deprivation goes up, maternal BMI also goes up in a roughly linear trend. And if I was to split the data randomly, say in the middle or the 20th percentile, if nothing was to go on, if Sure Start didn't exist, for instance, then I would be able to draw a line of best fit through either side of the data, so through all the blue dots and all the red dots, and the line of best fits would just meet because nothing went on. It's just a perfectly normal trend. However, on the counterfactual, if Sure Start did have an effect on the outcome, then we would start to notice a sort of bucking trend at the exact 20th percentile score mark, which is basically what we see in this graph here, that suddenly the sort of results and the data points for, say, maternal BMI would shift just as we reach over the threshold that was used to decide whether or not an area should get Sure Start or not. And that sort of gap that is denoted by the purple line there, how big that is what we would estimate as sort of the effect of Sure Start, of receiving Sure Start. And that's basically how regression discontinuity works. We're looking for jumps, bucks, or discontinuities, as the word is. So the real question is, when we have all this administrative data on children and their mothers, are we going to find this sort of bucking trend, this discontinuity, when we look at children who are born in certain areas? Well, there's over 40 different outcomes because there's a lot of data. So I'll just give you a quick rundown of our early key findings, which is, first of all, there is a noticeable shift in interactions with children's social care and rate of social care intervention. So within the first 5 years of a child's life, roughly a significant minority of children will be referred to children's services, 18%, and a significant proportion will also after referral, require an assessment for children in need. So that's 15.9% in our sample, which is quite a lot. However, from examining the data, by looking at the areas, we noticed that there's a dramatic dip in rates of intervention for children after you reach past that Sure Start cutoff point, such that basically Sure Start is associated with a 5.9% less likelihood to be referred and a 5.5% less likelihood to be initially assessed for a child in need, and also a 4.1% chance of requiring further action as a result of being assessed for being a child in need, which is basically quite substantial because it's essentially a reduction of up to 1/3 of the caseload. However, we find no effect on child protection or looked after status. And the second major thing that we sort of noticed is that this effect is particularly high for younger mothers. So for mothers who are aged 21 or under at childbirth. So the effect, as I mentioned before, it's something like 5% reduction in referrals and assessments, but for mothers who are 21 younger, this effect is something like 15% reduction within the first 5 years of life, which is quite dramatic. And what we also noticed was we for a subset of these children, the data is good enough to look at what happens in the first 9 years of their lives with regards to interactions with children's social care. And what we find is that the effect is pronounced in early years and then sort of stops after they receive Sure Start services, or at least there's no rebound effect. It doesn't get, nothing gets worse, but nothing gets particularly better. So for instance, what I mean is within the first 1 year, 2 years, 3 years of a child's life, what we see reductions in assessments and referrals in the first year, in the second year, in the third year, in the fourth year, in the fifth year. It keeps on increasing, and then it doesn't increase from years 6 onwards. Basically, as soon as a child reaches school age and they stop becoming eligible for Sure Start services. And this is only based on early evidence that we have so far, but we have looked at a very big range of indicators that I'll be glad to go into questions with in the questions section. But we don't really notice any sort of effects so far on breastfeeding, maternal BMI, birth weight, smoking, alcohol use during pregnancy. We don't have no evidence of any other sort of maternal and infant effect yet. And we also don't find any sort of other differences by subgroup based on employment status of the mother, sex of child, marital status, or number of previous births. It really is an effect that's largely driven by the age of the mother at the birth of the infant. And of course, I mean, I can answer a lot of questions, but it does bear saying that these are just, there's a number of limitations. First of all, these are only early results. So we have other maternal health indicators that we want to look at. So for later years of our data, we have better and better breastfeeding data. And also we have data on A&E and hospitalizations. So we're very interested to see whether or not Sure Start reduced level of inpatient episodes due to severe injuries, as has been reported for Sure Start in England. We want to see if we can replicate that for the Northern Ireland data, but we are due those results in the next coming months post-summer. And most of our data will always sort of be limited to the first 5 years of their life. And that's got to do with how old the cohort currently is now, rather than any sort of data limitations. However, there is a big data limitation in that the way that we do the administrative data linkage means that we can't link the birth data to data about school readiness or parenting skills. And we have no data on early identification of developmental delays in our data extract. So those are pretty big key policy outcomes of Sure Start. So there's some key outcomes that we just cannot cover. But I want to thanks to MatCHNet for supporting us in our early work in doing the evaluability assessment of this study, and I'm happy to answer any questions. And we're very thankful to the Honest Broker Service for allowing us access to this data, and the UKRI for funding this study.